have any expectations for us to talk about today?
Actually, what we are planning in Sri Lanka is that we are kind of new to FHIR, but there's a working group which is working on FHIR. Actually, what we need is that we have several different EMRs running, actually not only in the public sector, but also in the private sector. So we want an interoperability layer among all those EMRs. So we are working for FHIR profiling actually. So we need to know where should we begin. I mean, the total picture of how to get into the, the whole project.
Yeah, so we can start with that, and we have also other people so Luke and Shifundo, we are also working together on some specifications. So it will be good to also to hear other people. So Luke, Shifundo, if you want to chime in, let me just take that as a topic, as an open discussion topic. Couple of things that I think you should do to start. First of all, make sure that you have some training on FHIR. So if you go through the videos that we have in our blog, have you seen the videos that we made before the webinars?
Yeah, the 4 webinars we went through. Actually, we recommended for our group actually your 4 webinars. Yeah. Great.
So if you have gone through that, that's not a training. That's just a teaser to see this is how complex things can get. So it would be interesting if you get your hands on some FHIR training. If you've seen the videos, you know that the only real important thing is that you get an account on chat.fhir.org and you ask insistently there whatever questions, the beginner questions or advanced questions, you should always ask. And in one of the videos, I think it's the implementation guide one, I do talk a bit about how to get started. So you have to have engagement with your stakeholders. So how do we start with FHIR? Well, if you want to start with FHIR because it's a cool technology, that's great. If you have a project that actually says we should use FHIR on this, or we want to have international standards, that's much better. So, and once you have this, you can start developing your own skill set of the team and also developing your own process. This is something that I do recommend. So depending on how official it is, so if it's a small company, they just need to have one project, that's fine. You just do it one time and that's it. If it's a government, you might as well say, okay, who is going to approve the specifications? Are these specifications going to be maintained by the ministries, or are they going to be maintained by the community? And there is always a political struggle there. I can tell you that when I did that in Belgium, it was more than 1 year, and the discussions are still not finished to the detail to see who publishes what and who gets the right to say that something is complete. So there is a bit of a process between a technical person says, okay, I made the specifications, and the specifications are published. But the most important thing is the other way around, which is from the moment that someone says we need to make a medication prescription on FHIR, or we need to do, I don't know, an allergy repository on FHIR. From that moment until you have your specifications, the path is much longer. And in there's those two things. You have to have a process. So you have to have the skills to do this, and there's a bit of methodology that you can follow there to once you have the skills, that's something that you can follow. But also very important is that you have the right support or the right participation of the people there. So if it's an official government project, then you might as well say to someone that is officially appointed, hey, we will have this. How often do you want to review the specifications as we work on them? Or do you want to sit at the working table if you have, if you want to get into the FHIR details, or at least in the functional discussions? So try to engage them as much as they can, as much as they want, which doesn't mean engage them as much as you want. Engage them as much as they want and they can. So if they are not technical, don't bother dragging them down to the technical discussions. But if they are functional, there's a couple of things, and those things are you'll see this in the webinar, in the FHIR implementation guide webinar. So Start by identifying the use cases and keep a list of those use cases. So the things that you want to fulfill. Then go through what we have as logical models. So define the data that you need for each of those use cases. Normally, if your project scope is clear and is small enough, you should have not many data sets. So you should not have many data logical models. So if you're talking about the prescription, that can mean, well, I'm just going to send a prescription. That's just one data set. Or I'm going to send the prescriptions, check the updates on prescriptions, take care of the dispensing, take care of the treatment administration, take care of adverse events, and take care of pharmacovigilance. That's a much different scope, and that will not be just one data set. That will be many data sets, each data set for the different for each purpose. So on the medication that you prescribe, you will normally not have a lot number of a medication. On the medication you dispense, you do have normally a lot. You may have optionally a lot number of a medication that is dispensed. So these things, they mean different data sets, but it comes with identifying the use cases, try to build up the data models, and then the rest is a bit of mapping this, or using the more advanced technical FHIR skills, and say, okay, which resource would I use here? Do I need to extend this resource? Do I need to make some terminology changes? Do I need to say, okay, in my country, what are the medication products? Or what are the devices that I want to use for this? Or what are the types of allergy that we want to support in this use case? So I think the V model still applies. So start with, as much as possible, some understanding of what is the functionality. Don't wait for that. I mean, but that's now personal preference. Don't wait for all the functionality to be clear, because by that time it's a waterfall project. FHIR is an innovative technology. It allows you to go agile. So take advantage of that. And if you do not take advantage of that, you can have things like I've seen a few times, which is by the time that people have made a functional analysis, that functional analysis is so complete, so detailed, so thorough, and sometimes so wrong, that you don't have a chance to say, well, you know what, this requirement here is blocking that other requirement over there, which people might not think so, or you might have, I'm not remembering any example, but try to keep those things, not give one big step in the functional space and then a big step in the technical space. Try to keep those short steps, those steps shorter, one after the other, so that the functional people will see, okay, I don't understand what you guys are doing technically, and then you can make an example, and then, oh, this is the example of the prescription. And then the functional person will realize that, yes, this is exactly what, or no, there's something else that we miss. Or have you considered this use case? And then you say, no, but that's another data element, and then you add the data element. So then just go there by increments. And that's one of the things that is really good to do with FHIR, is that you can just add increments to this. And if you make a change to an example that is not according to the specifications, don't worry, the FHIR's ecosystem will let you know that this is not compatible. And then if you want to jump to implementations, you can roll out a server with those things. So this is the kind of steps that I would start by recommending. Now that I spoke too much and a lot, what is your reaction, Gayatri? What do you think?
Yeah, actually, I think that is where we should start. I mean, compile the use cases, what we really need, and then go on modifying some resources which are really necessary to cater those use cases. Actually, we need to. Sorry.
No, go ahead.
Yeah, I think we need to build a proper FHIR working group with, some technical skills, as well as some, inclusive of some clinicians also. So that is where we should begin. Yeah, thank you so much. We get it.
Try to do that, and if you have that, then you can always say, well, the process is, because you will have people trying to bypass the process, trying to boycott the process. This happens everywhere. It depends on how things get important. But once you have a process, it's the best defense that you have is that, no, we are following the process and anyone can join. So there's a thing called the FHIR community process, which also advocates for community participation, etc. So there's lots of good things to be to be used in having a process that allows people, or that pushes people for collaboration. And if you have that collaboration on the right level, so if you don't ask the clinicians to talk about FHIR extensions, and if you have your FHIR experts understanding that they don't have to feel uncomfortable and try to make up solutions if the requirements are not clear. So if I'm a technical guy doing something, I try to be perfectly at ease to say, no, this requirement is incomplete. I will not do anything with it until the requirement is complete. So but if this is a friendly talk, you know, if you say, no, let's wait until next week because the clinical group of experts, they are going to meet anyway. So now let's come up with a list of short questions to ask them. And then if you have this ping pong, this engagement, it really, really helps.
Yeah, got it. Thank you so much.
What is your project about, if you can disclose?
Actually, we are from the Ministry of Health Sri Lanka. We have several plans ongoing. Actually, we are in the phase of kind of formalizing, streamlining all the solutions that we have already, and building an interoperability layer to communicate. I mean, to get all the systems talking to each other. That is where, I mean, very initial phase, but we think that we can progress towards, you know, some kind of interoperability during at least within next couple of years.
Good. I don't know if you've seen, I don't know if people can read the chat before they joined, but I don't know if you joined already when Luke was posting the link to the Gazelle URL that I don't know. Chayatri, do you see that?
Yeah, I see one link.
I'll just share the screen. Sorry, maybe it's easier. Screen. Can you see this? Can you see my screen?
Yeah, I can see. Yes, yeah. I can see now.
So without forcing anything into the IHE actors, which I mean, just because that's not what we're discussing here, although it's the place where you should start. So if you have a specific functionality, just go to FHIR. But if you want to start with that design of the interoperability framework or the interoperability architecture, then start with IHE, I would recommend. And IHE has several actors and profiles and transactions, because what IHE does is to put things a bit more functionally. So one thing that I would advise is to look at this and say, okay, I have a thing called acquisition manager. So this is about imaging. Okay, so there's an actor which is a system that controls the use of acquisition modality instances. Okay, do I need that or not? And if you start making your own map of who needs to exchange what information with whom, if you start doing that on a functional level, so not on a file level, this is what will help you the most, because then you start seeing how dense is your network of entities that collaborate. And once you say that, for example, let me see if I have something here. Let me see if I see I just go to the ones that I know best. So this is kind of infrastructural, the barcode processor, so I will not use that one. But if you say that you have the medication dispenser, okay, so you have the actor that's a medication dispenser. So that's really clearly a functional description of what the system is supposed to be doing. Well, it says it's fulfilling the prescription. Sometimes it might not be a prescription; it just might be an over-the-counter dispense. But this is the kind of things that help us. And if you see, okay, I have IHE as a reference architecture, like what information actors should exchange what information with other actors. If you start making this map or starting to create this constellation of data exchange needs, then you can easily park the discussions. You can say, okay, we are talking about prescription here. We are not talking about pharmacovigilance. Then you can put that aside, deliberately and consciously, meaning that if the ministry says we really need pharmacovigilance, then we have to do pharmacovigilance. But if the ministry doesn't say anything, then we can bring it to the next discussion and say, hey, we really know that we should do pharmacovigilance, but not now, because now we want to focus on the prescription. That's what is the main requirement. And then they will they might say, yes, okay, let's not extend the scope too much. So if you use these reference actors, this reference architecture, it will help you. It will also help you in things like, so if I look at the medication dispenser, I could say, okay, then medication dispenser is also taking care of the supply chain. But then if you read about it, it's not. So you can say, well, this system here is doing a dispense, but they're not doing a dispense. They're actually doing supply tracking. So you can say, well, this system does not fit into our architecture. So I think you can, again, starting always with the functional side of these things, I think you can have a good beginning by starting to identify the functionalities that you want to have in your ecosystem, and who should exchange information with whom. It's not easy to do. I hope I'm not trying to make it sound, or it doesn't seem like I'm trying to make it sound simpler than it is. It is a lot of work. But it's not mystery work, you know. It takes some know-how and some experience, and takes some knowledge of what is out there, but it's not impossible to do. And it's a method to get to a consistent architecture, because then you say, okay, this is my country's reference architecture for interoperability. These are the actors that we support. These are the transactions that we support, and we rely on IHE or not, depends on, but I would advise that you do for those things. And then within this transaction, which is the prescription, which standards we use? Okay, this is FHIR. Okay, then it's fine. Then let's use FHIR for this. If it's about the imaging, then you might use FHIR and DICOM together. So I think there's a bit of methodology that you can use from that. That's what I'm just saying is pretty much the IHE methodology. So try to rely on that, and keep always focus on functional. Just one trick, I think it's in one of the videos, but what I usually do, I don't know if others have other tricks, but what I usually do is to go back and say, I put on the hat of one entity and I put on the hat of the other entity, and I try to imagine what is one entity saying to the other entity, and I'm trying to verbalize it always. So there's a difference between saying, here's the prescription, and here's a prescription, or I made a prescription. That's one thing. The other thing is, I made a prescription and I expect it to be dispensed, or please dispense this prescription. The language that you use there will indicate what it is that you're talking about. So it's a trick that I use many times. It's to understand and to explain, or when listening to the discussions, and I put it back to the clinical people, say. And I say these expressions. So I say, okay, are we talking about any prescribing system? For example, whether it's in a hospital, or whether it's a doctor at home, or whether it's a doctor in his office, any such type of systems, saying, here is a prescription, it can be dispensed, or here is something for you, specifically you, to dispense it. Those are two different things, and it helps, you know, have that dialogue on a verbal and functional level, and then worry about architecture, etc. It gets very complicated, but it's manageable still. But if you're starting, start with a very tiny scope. That's my best advice, I guess.
Yeah, thank you very much for that insight. Actually, what I get from this is actually you meant we have to build upon the reference architecture of IHE, and then, I mean, the functional use cases, and then go on deciding on which standards that we are going to use to cater those use cases. I mean, the functionalities. Yeah, I get it.
Try to keep track of that, because 6 months in, someone will say, oh, this use case is obvious, and then you'll have to say, well, it was not documented, so it's not, let's not agree that it was obvious, or depends, of course, how the team is working. But try to keep track of those, and it's not, so I mean, I'm just talking about process now, and I'm talking about my experience with working with and against health ministries. Try to keep this communication very lively, very open, and say, oh, here's the use case. We don't care about overly documenting this, but there's a repository, there's an inventory of our use cases. Why? Because we just need to know to get back to this to see when we do testing, etc. We need to see if we have our scope well under control, and this helps you a lot in different things. First of all, to make sure that the requirements are clear in the heads of people that require it. Sometimes people will tell that, no, this is clear, it's a prescription. And then you ask this question like, what is a prescription? Is it a request to do something, or is it just a statement that something is authorized and someone else can pick it up? Or is it a medication thing, or is it for other things? And these discussions, if you work on use case and if you make those use cases very concrete, then many times people will say, oh, I did not think of that. I did not realize of that. So of that difference. So this is very good for the dialogue. Yeah, and also helps the testing and the team feel less forced to do something that's not in scope. One thing that we did also in Belgium, I don't know, I mean, maybe it's more advanced, but also to bring the testing in. So when you do this, try to build the testing in scope as much as possible. So in Belgium, what we have is whenever someone makes a requirement, we say, sure, but we are the technical guys. We are not going to own that requirement. It's you as a clinical guy. You have to define that requirement, and we are going to define testing for that. But we don't decide if the testing is enough, because it's up to you to see. So we can make some testing, like what if I make a prescription and then delete the prescription and then reissue it again with a different thing? Should this be dispensed or not? Or what if I change the dosage after the prescription is dispensed? Lots of questions that can come up here. This is, you have to build up this list of possible exceptions and possible scenarios. But as you do this, if you have this dialogue between the technical and the clinical people, and if the testers are there, the testers will help really raise the flag and say, hey, I don't understand if this is really a medication, or what if the medication is not available, or what if the medication doesn't have a code or something like this. It really helps to have this very short feedback loops between the people. Does anyone else have any recommendations? Luke, I don't know if you have any ideas, any further recommendations?
I was just gonna ask, I guess, it sounded like from what you were saying, maybe have you been looking at what OpenHIE is putting out as well? Is that, or are you just doing something similar? And maybe it's not based on OpenHIE, but we were talking about the interoperability layer. I don't know if you were using the architecture or kind of, yeah, looking at the OpenHIE architecture, because that's also a good place potentially, yes, if you for your information exchange, if that's what you're talking about, having kind of the central exchange.
Actually, what we planned was, I mean, for the base architecture, it's OpenHIE. Actually, we are in the process of building up some services like provide registry, client registry, and as well as the facility registry. So also we are looking at the way that we are going to use the terminology services as well. So yeah, that is the idea.
Okay, great. I mean, yeah, that's a good thing to look at. I mean, the specification there also, kind of defines some of the workflows that you might be using to try to get, the software exchanging the information, and a lot of those are based on IHE specifications already. So it kind of gives you a good focus, which then obviously those are then, based on either FHIR or one of the other HL7 specifications for the most part. Well, yeah, I mean, from where that's focused, and there's certainly areas that are not fully defined yet. I'm not sure how much, as Jose was talking about pharmacy, I'm not sure how much pharmacy pieces are defined yet in OpenHIE, but it's certainly a good place to start for that. So I think that's a good, I think where you're looking is good, and there's also a lot of communities there that can help as you're kind of defining things and figuring out where how you want to do things. So that's another good place to connect with people that are going through the same thing. And there's also an implementers network, and they have a lot of calls, and that's also a good place to start with questions. I can kind of, let me see if I can find when those calls are.
Actually,
Yeah, I guess communities are the best place to get the hang of it. Yeah, we believe in communities actually. Yes, thank you so much for that suggestion.
Yep. And if you get more and more engaged with the communities, then yeah, these things, the same topics, the same things will appear over and over, which means that there's not much more to discover. So yeah, once you go to OpenHIE, you see that, well, it's based on IHE. Okay, once you go to IHE, you see that this is how it works. This is the way that the infrastructure works. There's some slight differences in the way that OpenHIE calls and documents things with the way that IHE does, but it's pretty much, it's almost the same thing. I think there's different names. So what OpenHIE calls workflows is pretty much what IHE calls transactions, if I'm not mistaken. So these are data exchange patterns. Yeah, so eventually things will become, it will become part of the same picture, not different disconnected pictures, because they are all relying on each other. Yeah, thanks, Luke, for the link. Yeah, and so Jeffrey, if you have the architecture, it will be interesting also. So when I mentioned what architecture is also interesting to see, yeah, which domains or which parts of this. So if you talk about, we are going to start with interoperability, that's very, very big. If you start, well, we are going to start with medication, then that's easier, but still big. If you start with, we just want to have the e-prescription, that's still very, very big, but it's more feasible. And one concrete thought that I have is try to get your team enabled with a scope as small as possible, so that they become proficient with the tools. So give them something that they can work with. So in the video for implementation guides, you'll see that I made an implementation guide for food allergies. That has very little value. I don't expect this to be any of use for anything, but the content itself. But the thing is that it's so small and it's so clear that once I do this, and if I make a server based on this, and if I make testing based on this, then I can sharpen my tools and I can develop my skills by focusing on, so the functionality is there, I know it very well, the rest is just my focus is on putting the tools together for this. And then once you finish this, or as you go through this, you gain some proficiency that will be very useful for other things. So concretely, like if you want to make a data model, then you use a logical model in FHIR. That's very easy. So once you enter the discussions about, I don't know, privacy or so, well, privacy is difficult, but when you enter things like referral prescriptions or referrals, if you order referrals, if you do that, there's a big difference in going there and say, okay, I don't know anything about order referrals, and we start FHIR with this versus saying, I don't know anything about order referrals, but the FHIR part I have already practiced in this little sandbox pilot project. So this is something that could help a lot in your adventures into FHIR. Yep. Any more ideas? Any more thoughts? Any more things to look at? I think we are all colleagues, so Chifundo, Luke, and myself, we have other places to talk. So take advantage of this call if you want to. Just ask as much as you want, or share as much as you want.
Yeah, actually, I wonder whether that you are holding any other sessions so that I can bring my other colleagues in to get some, their perspectives in.
Sure. Rhonda, I don't know when is the next FHIR.
Our next chat is December 7th, 18th. I'm going to ping you the registration right now. And then we won't be doing additional FHIR webinars until the new year, but we will, you'll see them come out then. There will be another chat just like this in about a month.
And because we already discussed, so the situation in Sri Lanka seems like a good stimulus for us. So we come to these calls as an open call. And so sometimes I was just talking to the colleagues today that we don't have an agenda topic or we don't have a theme to talk about. But we can do whatever people want. So if from Sri Lanka, if you say, okay, I'll bring 5 people, I'll bring 2 colleagues of mine, or just 1 more colleague, or I'll go alone and still want the same thing. But if you say, I want to have, or I would like to have a concrete example, or I would like to discuss a concrete example of how we can handle, for example, food allergies or whatever, just something that would start, so making it more concrete. How would we use all this thing about IHE versus OpenHIE versus FHIR and versus having teams, clinical teams, technical teams, testing teams, deployment teams? How does that work together? Feel free. So if you want to bring your teams, and not for abstract or fuzzy talks, but to just say let's simulate what would happen here. And then as we describe the process, like the process will be, well, for example, there will be a working group. Well, there will be 1 working group or many working groups, depends on how big you do this, but you'll have to have this discussion in Sri Lanka. Like, do we want to have 1 working group of FHIR or several working groups? Eventually you might need several, depends on how fast things can grow. And okay, how do we put those working groups in place? What do those working groups actually do? What do they take in as input and what do they produce as output? Is it officially published specifications, or the working group makes the candidate specifications and someone else has to approve them? Because if you're in the Ministry of Health, then you have you might want to rubber stamp that at the end. These kind of things, so the operational side of this and also the FHIR side of this, that could be an interesting topic for us to discuss. Feel free to bring it on.
Yeah, thank you so much. Yeah, I'll do that.
Great. Anything else? Any other ideas from anyone? If not, Chifundo, this is pretty much what we are going to do for the supply chain. We already identified in the white paper, we identified the kind of transactions that we are looking at. So that was a big discussion, focusing, so with a bunch of people, but focusing only on the functional side. We also derived a bit the data that we need. So we know that when we order something, we have a data set, but when we receive something, the data set is slightly different. So there were those discussions in IHE. And then what we are doing now is, and that's the thing with preparing the tools and the processes and the transactions, things that I was talking in the beginning. Once we have that, so as we go through the tools, then we can say, let's make these specifications themselves, and that's what we are doing. In some parts, the functionality will be clear, like for the supply transactions, that's going to be clear. In some other parts, it will be ambiguous or difficult to have one consensual model. For example, the product model. Everyone has a different model in their heads. I had one. I learned from the OpenHIE team that this model could be improved, and that will have lots of discussions on that. But we are following the same method. We start with the functionality, come up with the logical models. From there, we implement FHIR resources. If there are no FHIR resources, then we have to escalate within FHIR to say we need this, or we need HL7 to provide us these FHIR resources. And then we do the usual thing: use cases. We provide examples, we make the profiles, we validate those examples against the profiles to see if everything is fine, and then we start publishing those. And we make the test cases, etc., etc. So pretty much the same formula. It's like repetitions of the same pattern. There's nothing new here.
Yeah,
life is boring sometimes.
Boring is good sometimes.
Indeed, that's also just okay. Sorry, it's Friday, but let me make it a bit more formal. the fact that it is boring, it's a very, very good sign in terms of quality, because it is a reproducible process, or it becomes a reproducible process, which means that the way that two different people do the same thing is not that diverse. And when we look at quality, so if you look at DevOps and quality, if you have too much variance, then something is wrong. So it's not quality, because you can expect one person to do an excellent job and the other person to do an excellent job, but if they reach completely different conclusions, which one to rely on, and what guarantees, what do you have that the third person will not do something yet different? So we want to have this, you know, repeatable things, really like Bach. Sometimes you might see some genius there, but the most thing is like, it's genius how boring that is, and you know, how predictable, and how, not that I know anything about music, but how predictable the pattern, the fact that there is a pattern. So there is always a pattern. What is that pattern? That depends on what we are doing. But yeah, it's just repeating the same, trying to get to a point that people don't have to think when they do specifications, or people don't have to think much when they do specifications, because in many times people are not thinking too much. They have agendas, they have pressure, they have other things. And actually, just as one silly example, there was a discussion in one working group that there was a sudden urgency emergency to do things. Oh, we have to publish this tomorrow or next month or whatever. And the fact that we had a process that was really, really predictable and boring, like, no, the process says that, sure, we can do this, but then we still have to do that and that and that. So, okay, so we cannot publish tomorrow. We cannot do this in this way, or we cannot bypass this part of the process. At the end, it helped us, because if we did not do that, then we would have something that would be completely off the architecture, something that was not mature enough. So it really helps us to say, if you follow this process, and the process can be very fast or very slow, but if you follow the process, the guarantee that you have is that everyone knows how it got there, what happened, which is, if you're talking about legal standards, that's very, very important. So there has to be some auditability. When we talk about the process, or next time we talk, we can actually go through some of these things, like how do you submit feedback to the teams. So everyone can do whatever they want. We can have Jira, we can have email feedback. You can do all those things, but there is a couple of things that would be interesting to consider, and it's nice discussion to have. How do you engage these people in a consistent way, so that you know that if someone says tomorrow, why did this attribute change, or why does the value set change, that everyone can say, well, let's follow the process, because we know the process. Let's follow the process backwards and see where it could have changed. Okay, it could have changed by the working group. How does the working group change? Well, if they have a request, where is the list of requests? And if the list of requests is clear, then you know who requested that. So there's really lots of advantages in doing things high quality. And high quality is not Mozart. It's, in this case, high quality is Bach. And from what I know, Mozart was only Mozart genius because he was, in a very young age, boring playing boring piano from an early age. So he had this 10,000 hours of learning from an early phase. Then the genius can appear. Sorry for the musical analogy, but it's weekend anyway. So it's but the key aspect is that from a DevOps and quality perspective, you want things to be predictable. You want things to be low variance and boring. Okay, we have something down the chat. Okay. Do we have any other ideas, thoughts before we close?
I just want to thank you for this very insightful. I mean, the chat, it really helped us to realize where we are and where we should go. So thank you so much.
Bring it on. And next time we talk, maybe we take the case of Sri Lanka and make an example of say, okay, let's using only open tools. Let's make one example. Let's all together make one example of how Sri Lanka could do these things. And actually, maybe we can implement an implementation guide. Maybe we can put the feedback just to see how easy it is to do some of these things. So I'm looking forward to you bringing the team and the ideas and the needs, and especially the very clear or focused scope. So that's something to start gain proficiency. So I'm actually interested in that as well for our next talks.
Yeah,
So
sure,
thank you
sure.
for showing up.
Thank you so much.
Great. So if we don't have anything else, we should wrap up, I guess, Rhonda.
Yeah, I think so. Thanks so much for doing all this, everyone. Thanks, Jose, Luke, Shindo. Jayatri, it was great meeting you. And we will see you at the next fireside chat on December 17th. Thanks all.
Thank you.
Thank you.
Bye.
Bye.
Thanks a lot. Bye.